Well, there's a nice red button, and I sort of feel tempted, but when I hold it, it stays red. Maybe we're not. Okay. That works. Good afternoon, everyone. My name is Dipak, and I'm from the European Institute for Innovation Through Health Data. And that's all you need to know about me for today, because I'm only moderating, and I have 4 illustrious guests. But I have 2 announcements first. For those of you that are part of the short communication session that will follow this, please make sure you find Michael and you go up to the top corner with your presentation. Otherwise, you'll be speaking to a black screen. So can you do that while you're listening to this session? So still stay attention. And the other one is to remind you of this very warm invitation that is present for the end of the today and the buses. So please look at your sheet. Don't forget, if you miss the bus, you'll have to figure your own way out to get there. Okay, we are continuing on the theme of anonymisation and pseudonymisation, but with a very different take on the topic. And here I have 4 wonderful panelists who will each bring a very distinctive flavor to this topic. And we're going to go around 3 times. The first time, each of them is going to just take a minute to say who they are, what organization they work with, and what role they have in the organization, without telling you anything about health data. And they'll do that in a minute. And then we'll come back to question about the data. So, Maud, could you start? We'll do this in the order of the chairs, and then I'll go to the table, and we'll go in the order of the list after that.
Hello, my name is Maud de Crème. I'm French, and I work at the Foundation for Cardiometabolism and Nutrition, which is a research institution in Paris.
Thank you. My name is Petra Wilson. I work for a little organisation called Health Connect Partners, which works in, amongst other things, data protection, and I also have the pleasure of working with Dipak within IHD.
I think that's... Hi, my name is Daniela Will, and I'm a data protection officer of a Bavarian huge public clinic.
Hi, I'm Yassine Dakin. I'm head of legal of the Health Data Hub, which most likely will have a role as health data access bodies in the EHDS Regulation.
Thank you very much. So actually, they've taken a minute together rather than each, which is very efficient. So thank you all for that. Yeah, I know Pierre Reeve's anxious about the time, so you've already saved 3 minutes, which is great. So, dear panelists, the first question really is for us to learn a bit more about your current situation with health data. What do you do today? What are the practices that you adopt in order to make health data available and reusable for others? And so, Daniela, I'll start with you if you could, and just you tell us your... So really, this is your today story. What happens in your world at the moment?
Okay, can we just align it with catastrophe?
Oh,
no,
you can if you wish, with pleasure.
No, look, if you look at a huge clinic, and a clinic with very strong old roots and very different and diverse systems with no interfaces between them, where from time to time you have to print out things to type them off into the other system. Then you have an idea on how we can deal with research and how we collect together data that might be of interest for someone who wants to have for a secondary use. So what we currently try is to establish processes on how to export those data in a slightly standardized way, to have them secure in one place, and to have an idea in what way we will further on process them. What we do have is employees which doing that part-time. They're not study nurses full-time. They have 2 hours a week, or sometimes 2 hours a day, to do those experts, to collect the data, to collect the consents, to do all the bureaucracy, to fill their paperwork, etc., and then to send over the data to some sponsors who sometimes just say, send them by email, which is weird, honestly. So we have also, on the other side, a very broad variety of companies that work together with us on mostly joint controllership basis, with very different systems on how to upload the data and how to deal with the further steps here. Though that's my reality by now. And I try to standardize that, and it's not easy.
No. What about decision-making dilemmas? I mean, you've described a pretty old data landscape.
Yes.
You have a responsibility somehow in that to try to make sure good practice is upheld and the law is upheld.
Yep.
What are your pain points in all of that?
My pain point is money. We don't get money for doing research. We get money for taking care of patients. And we are not paid for collecting the data, for buying systems that have interfaces for those exports. Or we do not get any cent from our patients for doing anonymization. And my pain point is that the software suppliers, the system suppliers, do not offer proper standards. They asking us what we need. We do not know what we need because we don't know what will be required in the next 2-3 months, years, or so on. So my pain point are the software suppliers.
Right. And the lack of a financial business model
Of course.
around data reuse,
Right.
which I suspect is actually felt by a lot of hospitals and GP systems, healthcare providers who really, it's not in their business model, and yet somehow they're expected to do something. Let's move on to Petra next. Petra, will you tell us, because your role is somewhat different, so why don't you tell us what you do with data and what you see as the issues today?
Well, first of all, I'm slightly fraudulent because I don't do anything with data directly. What I do is support other people who are doing things with data. And I would divide that into broadly 3 types of activities. One, which is work that I do often in conjunction with Dipak, is being involved within projects or advising projects, and by projects I mean European Commission funded projects, IHI, IMI projects, or national level projects, on how they may make best use of data, whether that is something like developing a data management plan, doing data privacy impact assessments, helping them develop the right types of data privacy notices, or simply just being, if you like, the critical friend on what is the GDPR, the AI Act, and other legislation that impacts on the way in which data is used. Because I think one of the philosophies I personally have is that we need to make friends with all of the legislation that is around this field. The GDPR in particular is very often used by people as an excuse for not doing something, as an excuse for saying, I can't do that because GDPR says no, or it's all gone wrong because of GDPR. So I think that allowing people to make friends with the legislation and to see it as an enabler rather than as an inhibitor. That's one bucket of work. The other is actually very much more practical. And I work a lot with something called the European Association of Border Regions, because a lot of data protection activity and also a lot of work with data is very much clustered in large teaching hospitals, in big cities. And what happens in border regions where although the GDPR, European Health Data Space Regulation, and other European level legislation applies, they often have to, the practitioners in those areas often have to contend with 2 or even 3 different sets of interpretations. So just to give you a very practical example, I'm doing a piece of work at the moment on the Romanian, Hungarian, Serbian border, so 2 member states, 1 accession state, trying to help them develop a mechanism for sharing data across borders for primary care. Now, logically, you would think, well, the GDPR provides all that, and soon the EHDS will will provide better channels for it. But in practice, in the day-to-day practice of a clinic, trying to share data across a border, that's not a reality, because you've got the real practices in place in a clinic, and whether that's IT systems that don't talk to each other, or people who don't talk to each other, or who don't talk the same language, whether that's a human language or an IT language, there are a lot of challenges there. So that's another one of the practical levels I do. And then the other one, I feel, again, very beholden to you, Dipak, because you're actually wearing the badge and I'm not,
Yes.
which is data saves lives. I think one of the other things that I try to do a lot is to really foster better understanding amongst citizens and patients of why sharing data and why making data available for secondary use is a good thing, and to loop back to the beginning of why the GDPR is your friend, how the legislation can protect and can be useful. So I would say there's sort of three things that I do around data.
Okay, thank you very much. Maud, we'll come to you. And Maud has a couple of diagrams to back up your verbal. So can we have the first of those slides, please? Thank you.
We can pass this one. As I said, I work in I'm a head of legal affairs in an institute. I'm sorry. I'm a slide person, but this is not really very nice design. But
would you rather stand or?
Yeah, I will stand. So
It's up to you.
I just wanted to. I think that some people have the same job as I do. So I wanted to share concretely what we're doing. So we work with a hospital, the biggest hospitals in Paris, and they provide primary care, and there's primary processing of health data. This is not what we do. What we do is research. So we do use and rely on this data. But in my institute, we have a very high throughput technology for phenotyping in depth the patients. So our internal research is based on secondary use of care data and providing new data. We do this alone or through academic collaborative research or private collaborative research. Can we go to the next? And this is what is new, and in relation to the title of this panel, we also, as a publicly associated structure, we have to think about open science and how we do this, because this is an obligation. And the HDH, the French HDAB or future HDAB, is actually has been providing these last years some programs and funded programs that helps share the data with a larger audience. I have underlined here that this is not in a collaborative capacity, which is something very important when you share data, because I personally don't think in sharing data without collaboration, but this is something else. But we will do it anyway, and this is not the same work as what is on the left panel. Can we go to the next slide, please? Yes, and can you, so this is what I was talking about. There are grants. We had grants to do these programs. So the special aspect of this is important when you keep in mind the EHDS and the secondary use in the EHDS, because what the French HDAB has been co-funding is they gave us some money to share data in an anonymized way, but to perform good scientific things and through data challenges. In this instance, we did it through a subcontractor, so a private platform that can organize hackathons or data challenges. Can you? Yeah. And we one of the projects we have is called Cardiac, and the problems we have with this kind of projects in anonymization is that it's a rare disease, and what we are aiming at is identifying through whole genome sequencing polymorphisms that are predictive of disease progression. So you see, for anonymization, rare disease and genetics, whole genome genetics, a bit of a problem. So it was a challenge, and this is what we're doing now.
Good, thank you. And it's nice you've left us with that challenge, because clearly it is a critical. I'm involved in a European project on cardiomyopathy. I've interviewed cardiologists who really, really struggle with what you just said. So without that novel research, clinical practice and therefore real patients are currently in a dilemma. And so I think it's really important. So we really have to look at this balance between making for data protection perfection and saving lives, which you've hinted at very nicely through this example. Thank you. Now, you refer to the Health Data Hub, and I think everybody who is not French in this audience will have heard of it too. It is one of the big, exciting European landmarks that is about trying to scale up data access and use. We think so. So why don't you tell us, Yassine?
Thank you for this kind presentation, and thank you for this. And I will not talk about those data challenges, so it's good that you mentioned them. Yeah, so the Health Data Hub, to a quick word. So we are a public structure created in 2019, and in order to help to facilitate secondary use of health data. And what I'm gonna talk about today is about two use cases that of the future HDAB. And how we're doing it right now, and what are the main challenges we're facing right now. So the two use cases are the following. First one, in the future EHDS, you will have data user could have access to pseudonymized data through a secured SPE from the HDAB or for a trusted data holder, but this is not my point here. So access to pseudonymized data in secure processing environment, first use case. And the second one is access to data by the HDAB. And those are two different use cases, and they both have challenges. So the first one is to give access to pseudonymized data. So as I see, I don't have to precise what is pseudonymization, and we already go in depth in this notion before. So the main thing to say about it from our perspective is that we only access already pseudonymized data. So this is the first point, but they're still linkable to a person, of course. And we also have some specific regulation in France, notably the French security referential of the SNDS, which is a national health system, that provide us rigorous requirements on pseudonymization that imposes really, and it's not guidelines, it's imposition of rules, like having a cryptographic operation to have the pseudonym, to have to prevent collision effect and so on. So that's linked or that looks like, let's say, what the requirements we've seen previously with EDPB. And also some principle is that as HDS we cannot have both the data, the identification data and the pseudonym, and also we have some rule like if there is a leak of pseudonym, we have to renew all the pseudonym. We have also an imposition to renew all the pseudonym we have every 6 years. So we can say this is best practice imposed to us by regulation. And basically, what is the main use cases we're facing right now is that people, let's say, a data holder. And it's quite similar than EHDS, so you will see what I'm talking about. It's like there is a data holder providing us data. They have to pseudonymize the data before sending it to us, that there is an obligation for them to pseudonymize data. When the data come in our SPE, we put another level of pseudonymization. And after that, when a data user wants to use the data, we had another layer of pseudonymization in order to have different pseudonym in all the chain. We also have more specific security measures to prevent or to the identification, because as it had been said previously, change the direct identifier with a pseudonym isn't sufficient to prevent direct linkage between information and the person, and we have all a process to identify what we call quasi-identifiant. I don't know, quasi-identifier. I try it. Let's and identify it and apply process on this, like randomization, generalization, suppression, and at the end of this process, so the data user will have access to data in an analysis, space analysis in the SPE, so secure space in the SPE, where he can pursue his research, and at the end, often he will want to export results. And this is quite an important thing, is that the result have to be anonymized, and so we provide also guidance in this matter. And so this is the first use case, so pseudonymization along the line and anonymization to export data. And the second use case is what we call request on demand. It's mostly civilian society or association, patient association, for example. It's when people they have a question and they ask us to do the process. Like, how many people have diabetes in Paris in the last 2 years, let's say. And so in this situation, which looks like the data access request in the EHDS, we're doing the processing. We're accessing the pseudonymized data in the main database that we have, and we provide indicators. And this is also challenges because, one, we have to make sure those are anonymous indicator, and also there is a responsibility in with the recipient is that they also the anonymized data it is also needed that the anonymized data are still anonymized in their hands, because maybe they have other information on this specific case, and in this event, the data will be identifiable. So that was the two use cases of the EHDS and the main challenges we are facing.
Thank you. That's very interesting. And of course, it's very nice that you've interwoven properties of the data and the technology that wraps the data and adds safeguards, because it's very important not to disconnect the two. The database doesn't live on the street waiting for everybody to pick it up. It lives inside an environment which is protecting it, limiting access, and auditing access. And I think that's very important. So that's great. I'm now going to come to question 2, if you like, which is, you've described a little bit what you're presently doing and what the present situation is, with some negatives as well as positives about today. What about going forward? We are now in a world where we hope the data landscape is going to scale up. We hope that people will value data more, and that valuing of data more may translate, Daniela, no promises, into saying actually maybe external agencies, data user agencies, should consider investing and supporting the under-resourced players who are the people creating the magic data that everybody else wants. So I'm not saying to you respond to that financial dream of mine, but what would you see as being the way forward? What do you see? What might tomorrow look like, or where would you see best practices emerging that you would like to see?
Thanks for that. Really, also with the view on the EHDS, and also, is it okay? Is it working? Okay, great. With the EHDS and also what we say, we want to save lives. For that, we need the data. And I think, and I love what you said, that we have different roles, and one role is to talk to the people and make them understand and bring trust to the patients, because that's what we need first. We need their trust in that spending their data is a good thing, and they can feel secure that there's nothing wrong with that. I think that's the most important thing. Second is we need to say goodbye to consent. To ask an 85-year-old patient whether he is able to give consent to spending his data to a study is impossible. Not only from the patient side, who is not willing to understand that, but also on the side of the clinical person who has to spend time explaining the data processing. And by now, I'm right in the middle between the medical area and the legal area, trying to also translate all these requirements. And what I see, and I think you agree, is that we have very different levels of expertise out there. Also on the side of the researcher, who are thinking very from the medical side, but not from the legal side. And they ask really weird questions, and they provide really weird contracts where you say, excuse me, or consent forms or data protection information where you say, excuse me, who wrote that? Perplexity? Perplexity might make it better. And we now in the clinic have the role to nonetheless make it possible and try to invest time and rewrite these documents and so on and so forth. So what I saw in Germany, which I think is a good approach, they had now a paper on the governmental area where they standardized the processing for research and say, okay, this is how a joint controller contract looks like. Now, stick to it. This is how the roles are, and the sponsor, the research company, has to ensure that data protection information is right, the consent is right. You as a clinic must not do anything anymore. This is great for us because it saves time. And I would love to have such a standard on a European basis. And on the other hand, I would love to have a standardized training and competence workshops for my data protection colleagues in the clinics out there. Because I have the feeling I do not know anything. But sometimes I have the feeling they know less. And when I look at the first thing what I said is we need the trust of our patients, and we need the trust of our doctors that they spend the data of their patients for that research. Then we need experts on this side to explain it and to pave the way. And that's what future should look like.
Brilliant. Pierre-Yves, I think your academy now has a clear vote in favour. Okay, it has a job now to do. Petra.
Well, Daniela, you've taken some of my points of what good will look like, but I'm going to go back.
That's a good thing.
Good.
Yeah.
I'm going to go back to sort of my three overarching issues. So, under the heading of making friends with the law and making it work for us, I think we are on a different and new trajectory. I think the way in which the European Commission is approaching legislation now with the EHDS, with the AI Act, with the flexibility that it has had to adopt with the Medical Devices Regulation because we just weren't ready in time. We're in a better place because I think many of you will know we have, for example, the AI office. We are going to have an EHDS help desk. We are going to have an approach to a sort of a much more supporting role rather than legislation being top down. Follow the legislation. If you don't, you'll eventually end up in front of the ECJ, and then we'll have lovely rulings like the SRB ruling on everything will be crystal clear, or maybe not. But we will, I think we're moving into a better place in terms of really creating an environment where people feel much more able to ask and then produce something useful and move away from the 200-page data protection notice, because unless I put absolutely everything in there, some horrible lawyer is going to come and get me. So I think we're getting to the right place. I'm not sure we're there yet, but I really see a change in attitude and change in approach. That could feed well into building greater trust. You used the word, and I think that's actually the thing that we most need to get to, because I still think very many people in their hearts would quite like health data to be used for either having themselves treated or for the good of society. But building that trust that the researchers, the hospital, the healthcare practitioner in front of me actually have my data interests at heart is a trust that we still have to earn and develop. And I think the real crux point of that, and we'll learn whether we've managed to do that well, is when we see what happens when the EHDS opt-out clauses or mechanisms become adopted at member state. So last week, the TEDAS meetings took place, and I was very encouraged from those that there was a lot of discussion about opt-out being what they call granular. So you could be able to opt out in different ways. You could say, for example, I want my data to be used by anybody but a tobacco company, or I want all my data to be used other than data relating to my pregnancies, or I want all my data to be used up to X age. And I think as we manage to build that granularity and give people the right information so they understand how data can be used, we'll build the trust. But I'm frightened that some countries will maybe not have the money and time to invest in building that kind of granularity, and then we could have the risk of a mass opt-out. And if we have a mass opt-out, it will take a long time to rebuild the trust to get the data usable. So I'm hopeful because I think we're going in the right direction, but I think there is a big risk that something will, to use an English expression, spook the horses, and there will be a lot of people who decide to opt out of their data being usable through the European health data space, and that will be a big shame.
Yes, I mean, it's sometimes called fake news, but yes, that kind of stuff, some vulnerable groups are very vulnerable to that, absolutely, and we need to consider how we mitigate that risk. Well said. Maud, you've got another couple of diagrams for us as well as some conversation.
I have made it. And thank you, Petra and Daniela, because you gave the very important and fundamental questions, and I'm going back to the ground level, which is what we practice every day, and I think that is completely in line with what you're saying. I must say in France we are very lucky because the legal basis for handling the data is non-objection, so consent is out of, and that is very practical. And we do a lot of option in our notification letters. We do have several options that the patient can adhere to or not, and we translate it into our ECRF, so it's completely traceable. Again, with the same kind of approach, the question for me was, what should good practice be? And in our case, one of the good practices anticipating the future use of the data from collection, and that was repeated several times this morning in one of the presentations. And we do this not only by talking about future research when primary care is being provided, but also at the first level of research. We have a lot of cohorts. We are dealing with chronic diseases, and so our cohort can be up to 10,000 patients and 30 years of follow-up. So we provide documentation, and from the beginning, we talk about all the different uses that could be made. So, and we talk about anonymization, about profiling, and we discuss this and explain the rights of the patients. And we also have a transparency portal where all the new information are provided regarding, for example, the new recipients. And also we're trying to do something, and I think it's very important, it's to talk about science and talk about the results. This is important that in the same page you're talking about their rights and what you want them to allow you to do. You talk about the results and the benefits for them or the society. And if you are very good, we have not reached that point yet, you create a community, so a platform with a patient community. And a French cohort that is called Constance, that has included 200,000 volunteers, has such a strong community that they actually created an association, and they discuss, they have webinars, and they decide, and they really are stakeholders of the research. And I think this is a very good example. Can we go to... Yes, and in my institute, because the HDAB and the HDS, as you may have understood, I think it's not the only way we're going to share data, and we have to do the same approach of data spaces, but let's say local data spaces. And this is what we are doing through funding by the European Union, and we're creating data spaces where you have a shared governance, where you build trustworthy environments and shared rules. And this is all about interoperability at the level of the data, at the level of the legal aspects, of the technical and informatics. And this is quite difficult to build, but this is supported by the European Union. And this also includes all the research we're doing. And we also are trying to include the patients in our data spaces. Can you change the slide? I know. Yes, and I wanted to tell you that how we handle the difficulties, and I think this was more or less approach before. We do it through a transdisciplinary approach. We are very lucky in my institutions because we are like 60 people dealing with a community of 1,000 scientists. But still, we are a small structure, and that is built with all the expertise around the projects. And we are dealing with the different projects by project mode. So we are not different expertise and sequential intervention. We always are all at the same time on the same project with the same information. And which means that, for example, in the cardiomyopathy example I gave you, all the time the investigator, the scientist, the geneticist, the data manager, the data scientist, the project manager and the DPO, they're working together all the time. And one of the first things, and the DPO especially, needs to interact directly with each of these persons. It's not, if you do anonymization, if you do AI, if you do any specific technique like federated learning, or even worse with Gen AI, you need to be all together, talking together. And you need to establish a common vocabulary. I mean, because the French language, the legal language, is a bit of a false friend, because some words don't have the same meaning from the legal point of view. And you need to be able to listen to the others and to the other needs, and that goes in all the directions. And we do co-construct our projects. So as a legal actor, a DPO, I am not a support. I'm not a support team. I am in the team, and this is very important. Can we have this, the next and last? Yes, the steps required, for example, for anonymization. I just want to give you a very simple example. The first thing that I had to explain what is anonymization, and this is really from the legal point of view. So what is individualization? What is this is okay when with a data manager we can find quickly. We agree on what would be a statistical analysis of the individualization. Inference is also something that the data scientist or the clinician agree with me. Correlation becomes a bit difficult because all the publications you have with correlation, for example, people are just comparing two databases, the one before the anonymization, the one after the anonymization. And when I said no correlation, you have to go about what is in around us, what sort of public data exists, and so on. So we need to discuss these aspects too and imagine and know which data is out there. And so this takes some time. one very funny aspect is the literature. For example, I asked the data scientists to read and find articles about anonymization. And very quickly, I realized that they only had articles. So we had to ignore some of the articles because they were by American teams, and actually they do not meet the criteria of the European legal framework. But when I was looking myself for articles on anonymization, I went to articles about re-identification, and they had not one article about re-identification. They only had articles about anonymizing. And this is interesting how, and I had to come back several times to say, okay, but look, there are articles about re-identification, and if you have the two articles, one going this way and that way, you realize that something is problematic. So we can't trust, And the most difficult point was to be really limited in the scientific questions when we are with anonymization. And it was difficult because they had to reduce the scientific question, because otherwise we would never reach anonymization. And you have to accept that this is an exercise that is of limited interest, I would say, from a scientific point of view. And this is also something that needed a lot of discussion. So this is what I wanted to share with you about how we manage.
Thank you. That's really interesting. Can I just ask you one quick follow-up question? It's nice you've got a list of different people involved, and the cross-disciplinary nature is really important. Did you find that they really have a poor understanding of each other's worldview? Or did you find it quite easy to get these people to talk to each other? And Daniela, you've also had to have the same experience. So I'll come back to you with that. But
no, in my institute, I do a lot of presentation regarding GDPR and data protection. So they have basically, but the thing is, people forget very, very quickly. So this is a project that has been going on for 2 years. And I realized that if I don't do the same message again every 6 months, it's down the drain. So, but it's quite normal. I mean, it's not their area. And you do have a real problem for me, and this is much more important than the data protection problem these days, is the fact that clinicians are not up to date regarding AI, and data scientists are imposing a lot of decisions that will impact healthcare. That is really frightening. And many data scientists think that with the data, they're going to manage and find very nice things. And I think this is a much more worrying aspects of all
Thank
this.
you. So as an appetizer, this time tomorrow, we have a panel, which I'm also moderating, because Pierre keeps asking me nicely, on AI adoption. So the topic you've just hinted at will be discussed tomorrow. So you can't miss tomorrow. Before coming to you, I'd like to give Yassine a chance for his second answer, if that's all right. So can I ask you to now tell us, I would almost say you presented such a rich and relatively advanced previous answer. So could it be your dreams for tomorrow are already met? Or do you still have dreams for tomorrow for things to be even better?
Yeah, I think we have still a lot of works, okay. and everyone. I share the concern about trust and the concern about the risk of massive opt-out. I think we should be very careful about this, because and I think this is linked to, let's say, two main issues, but I know this is there is more, but there is security and information security, because every leak of data contributes to sorry, I lose the word, but to fragilize the trust. And the more fragile the trust is, the more opt-out we might have, and the less research we will be able to conduct. So we have to think trust and research as the main, the two pieces of the same objective. And so on security, so we have yeah, of course, there is a lot of work done in France and by the HDS on pseudonymization and anonymisation, but there is also a responsibility for us to keep doing the work and keep improving and improving our technique because technology evolves. There is also responsibility for all the data holder and data user because data holder are the one pseudonymizing data and they are the one that process data in the primary use, and we can have a strong secondary use data space if there is leak on the primary use, so and which is more sensitive because there is need and crucial need to identifying data. So there is responsibility on both sides, and like I said earlier, on the data user, when they extract anonymized data or when we provide them or will provide them anonymized data, there is still risk that those data will be in the future identifiable. So there is a constant monitoring of those data in order to take care of the information, sensitive information about us, let's say, because it's our data too. And so this is the first point. The second point is, I have not planned to talk about this, but the financial issues is quite important, and there is, and I'll take this as an opportunity to talk about the guidelines of TEDAS 2. I don't know if you know what is TEDAS 2. You mentioned it briefly earlier. This is a joint action in order to anticipate EHDS, and there are several guidelines that are open to public consultation right now until the 30th November. And in those guidelines, there are one about pseudonymization and anonymization, and so this is very crucial to have feedbacks on every people on every country, because we will need that the data is that the recommendations are usable in every country, because nobody has the same practices. So we need a secure process around Europe. And also there are guidelines on fees, because there is a crucial issue with fees, because so a brief digression, I will be brief, but the Data Governance Act as constraints the fees public data access public access bodies could ask. In the Data Governance Act, when a public body is providing access to data, it can only ask for fees for the costs linked to the action of putting data available to others. So all the action that you're talking about combining data, collecting data, labeling data, quality, and all those are erased, are not covered. And the EHDS has put an exception of the Data Governance Act and opened a door to collect fees for those actions. But this is a theory, and the reality is exactly what are the costs that will be that we can ask. What are the costs that could? Sorry, I cannot find a correct way to formulate it, but you understand. Yeah, how existed? Yeah, this is simpler, and there is guidelines on fee also. So it's very important to provide also feedbacks, because we don't process data in the same way in different countries. So this is my two very practical action.
Okay, this is now a big worry to me. Pierre-Yves, I think could we have the cocktail here and just keep going until midnight? There are so many topics my lovely panel have already introduced. I'm just going to let Daniela come back on the one point that I didn't allow you to speak on straight away, but you were nodding as Maud's, we can still see this slide, you can't, but do you want to respond to the issue of working across different specialty groups and try to get aligned understandings?
I don't want to sound too depressive.
But
first of all, any clinics, hospitals here available? Someone from hospital? Okay.
How many of you are data protection officers for a healthcare organization, healthcare delivery organization,
Okay.
like a hospital or a GP practice or a region. A number of people are.
Okay,
so
question.
they're in the same hot seat.
Question. In your company, in your hospital, are there more than one person responsible for data protection consulting, etc.? More than one, hands up. Great. More than two? More than three? Okay. So what we see here is what I see there. Of course I would love to interact. Yes, we all would. But I have 20 hours a day, 7 days a week. And I feel right at the moment that I should invest 24 hours a day, 7 days a week, to consult my hospital, to consult my doctors, the patients, my colleagues in the IT segment, etc., in the area of data protection. To be involved in such a project, and you named something very interesting, DPIA, Data Protection Impact Assessments. Also something that I do by hobby or so, I don't know. So yes, that is highly important, and we need to come in contact, and I don't have a clue what the doctors need, and I sit down with them by sometimes a couple of cups of coffee to understand their wordings and their approaches, their perspectives, and they are completely different from mine. And I try not to bother them with legal phrases. It's very important. But I try to manage that, and therefore, yes, right, but we are not enough people to do that.
Mm-hmm. Okay, well, I think that's a very honest, I think very heartfelt communication to us. So
And I think you all agree, right?
Thank you for that. So it's really, really important, and it's under-resourced and probably undervalued. So thanks a lot for that. I now am going to ask a final question, actually the punchline question, because I haven't actually told you, dear audience, why we conceived this panel. I wanted to leave it until now, because things are about to get a little bit more challenging in this space. So the European Health Data Space Regulation, as I'm sure you all know, because even I spoke about it 2 years ago in your first conference, Pierre-Yves, it has roughly two big parts. It has a part about what's called primary use, which is not in scope for today, which is about enabling a very rich and detailed summary about each person to travel around Europe so they're safe if they receive healthcare elsewhere. Not for today, very important. Number two, which is the topic of today, is this set of measures to scale up the availability of data for research. And that's about having a mechanism which, Yassine, you've already, in a way, because you're a prototype, you've already hinted about how that works. But people who want to have data hunt through a data catalog, which people who've got data have populated to describe their data. And when they find the data they want to use for a piece of research or public health or health services investigation, they approach a body which is normally at a national level, but they can, for big countries, be regional level, called a health data access body, who will decide if they can be permitted to have the data for their purposes, because there is a limit to what you're allowed to use data for. And if so, then they will mediate the data access relationship. They'll put it, as Yassine told us, in a secure processing environment and audit it. But the regulation introduces a very important additional measure, which is where it's appropriate, the health data access body will perform the anonymization or pseudonymization or linkage. It will have powers to perform those functions. Now, what I was trying to imagine is how will that work? The only way that a health data access body can perform anonymization is if it receives data that is not anonymized. Otherwise, it's already anonymized. That means somebody who has data is making data available to a health data access body that is not anonymised. In other words, it's GDPR personal data. In other words, they have to have a legal basis for doing so. So the GDPR gives the health data access body the legal basis for receiving and anonymizing the data. But what about the data source, the origin? Do they have a legal basis for parting with it? And then I began thinking about a hospital DPO, saying, well, actually, hospitals are among the players for whom this provision was especially made, because, as we've had as a first-hand witness, they don't have the resources and the staff and the expertise to perform the anonymisation. So we're saying to our lovely healthcare organisations, don't worry, send your identifiable data to the health data access body and they'll do it for you. Sounds very sweet, until you think, hold on a minute. Are we asking a healthcare organisation to part and send to an organisation that did not exist when the data were collected, when patients were looked at in the eye and said, trust me, I'm a doctor, or whatever they said? How is this going to work at the sending end as opposed to the receiving end? And I think we've heard enough from Yassine to feel actually the receiving end is probably pretty good. That's how you've communicated. You've impressed me. I think it's pretty good, but what about the sending end? And here I'd like to go to people and imagine the sending end. Does this introduce new complexity, or am I just getting all, panicky for no good reason? So that's what I would like to hear. So Daniela, you have to come first. Am I getting panicky for no reason?
No. My clear question, is it something where a supervisory authority would say, excuse me, what did you do? I would have something to say here. And therefore my question would be, whilst the regulators are currently discussing also kind of a refurbishment of the GDPR in some parts, might it be a good idea to bring something into this really weird Article 9 that gives me as a clinic the opportunity to hand over the data without having a high compliance risk? That would my option, but I see no other.
And without that, would you feel quite nervous complying?
Of course, I would not. I would now ask some legal persons whether they can give me like a
Petra, you've got some hand-holding here to do.
Yeah, please give me something that tells me that's okay. You can tell your clinic to do that because it's not illegal. But I doubt that some lawyer would do that, actually.
Petra, are you imagining having to hold some new hands on this topic?
Well, in theory, the European Health Data Space Regulation does this because it says very explicitly that it extends the legal base in Article 92H, removes, or rather, so 92H is normally read in conjunction with Article 89, which is national level legislation. This is or EU level. EHDS is that EU level legislation that gives the legal basis to Article 92H. So you do have, I'd say there is an easy answer is, yes, legally you can do it. However, and I go back to what I've said before, you also have to build trust. You also have to satisfy the people who pay the insurance bill of the hospital that this is appropriate, and not just that there is a legal base. So I don't think it is entirely solved with that, but I think the European Health Data Space Regulation, and in due course the board that it will establish, will create guidelines and principles and rules that makes it operational. The risk, however, I think, is that unless that board is strong, unless we really drive a good, cohesive way of working across the health data access bodies across the 27 member states, and knowing, for example, that Spain intends to create 12 HDABs, and that Germany, with its federation system, will, even if there is one national body, there will be variations. The risk of fragmentation, the risk of going back to the fragmentation that we saw in the GDPR is very significant. And the fragmentation, to use your word, Yassine, can then lead to fragilization of the trust. And that's where the whole thing could go wrong. May I just take a moment to suggest a possible other route, though?
No, go ahead.
So we had a very interesting presentation before, digging deep into the various cases that the ECJ has considered on what is anonymisation, what is pseudonymisation, essentially saying, when does GDPR apply, when does it not apply? And the answer, however you interpret those cases, and maybe the guidelines will be very useful, but the bottom line is nobody knows. We don't know where anonymisation begins and ends. We don't know when something is pseudonymized. The TEDx guidelines that are now up for consultation say again, it's all context specific. My plea would be, if we can do it, can we, and the GDPR is going to be reviewed. I know this isn't in the pipeline for review, but can we make a plea for getting rid of this distinction between anonymized and pseudonymized data, because it does nothing to build trust amongst individuals. If a bunch of lawyers and the European Court of Justice can't really decide where the line is, how on earth can we explain to an 85-year-old patient, it's okay, it's going to be anonymized? But, by the way, if we find something that is going to change your healthcare, we'll de-anonymise it and we'll come back to you to make sure that you're properly looked after.
Yes.
It doesn't make sense. So my personal plea to get away from this fear is to really look much more creatively at what do we mean by data minimization? How do we make sure that the right amount of data is available to answer a valid scientific question? And what would be an appropriate data protection measure for that? And walk away from this idea of anonymized, GDPR doesn't apply, sorry, data subject, you've actually lost all your rights and interests because GDPR doesn't apply. Pseudonymization, don't really know what it is. Mm-hmm. So.
Well, I really support the fact that there is actually a really big grey zone in the middle. And actually, in a way, legislation can't cope with that very well, and it's best not to try. Maud, when you were presenting your slides, especially the first ones, actually, you spoke about the fact that you very much prefer a collaboration relationship. You emphasized that, I think, a couple of times. The EHDS is really a non-collaborative model. And so now this mechanism for you making data available that has maybe not been robustly de-identified, although maybe you'll always do it. You may always anonymize before you give. But this whole business of making the data available through a health data access body to do additional things, maybe to do linkage that you couldn't do, what's that going to do for you, and how do you feel about that process? How will your organization handle this?
Well, the first thing is maybe we will be using data from others.
Okay, so you might actually have the data and
yes,
be able to do the linkage.
Because we have the internal expertise to. So I wouldn't throw away this. I guess, I mean, I've been working for a long time in very specific environments and research and translational research. So I every day talk with people with a very high level and very specific and very exploratory objectives. These objectives may not be the only one on Earth, and I guess that, for example, for a startup that wants to test and see quickly if their idea is working and so on, I mean, there are needs. They are not ours, but there are needs. So I understand that this is that this EHDS is a good thing, no problem. And I personally, in a very specific context, that is the French context, where the healthcare system is very good and is based on solidarity, I think that the question of are these data a public good is a very important question, and for me they are. But because there is a certain context, because we are paying for altogether for this system to be working. And this is, I think that regarding pseudonymization and going and anonymization and maybe putting some distance with these debates, I think that if the authorities really talked about this, these data are public good, how do we in a country, in a democracy, handle public good? Because from the legal point of view, public goods, this is something old, and this is something we know we can infer from other legal areas. There's a very interesting story about public goods, how they become public goods, how they are not public goods anymore. So I think this is a very important question, and the fee aspect is a bit of a problem with these public goods, because we are not. When I'm with hospitals and we need this money, this is quite sure, but I don't think that it's through the punctual fees. I think there should be a contract where some people are tasked with getting the data, clearing them, adding value, and these people should have a permanent, funding for that. And when we give access to the data, we are not talking about money, because this is, for me, this is really not a good thing. And the fact that the different states are not looking at this that way, saying we will have funding for collecting the data and upgrading them, because they are not very good. From our point of view, hospital data have a real problem, and using them like this is not very good. So the work my institution does is absolutely paramount. And I'm very frustrated by the fact that we are not taking the question this way, saying, no, public good, access to as many people as possible who are innovators, and paying for people who are collecting the data.
That's very well said. I really support the way you've put that. When I've run patient focus groups or interviewed patients or patient organizations, really I would say probably over the last 15 years, because I've often been involved in data initiatives, I would say there is a consistent message that has always come through from the patient voice, which is that they don't want the data monetized, profiteered. And I know that one of the big drivers behind the EHDS approach to fees is to avoid data becoming a buying and selling, profit-making, exploitative resource. So I think the public good spirit was an intent. The trouble is that when they were thinking about saying, let the fees be a cost recovery process, they weren't thinking holistically about the costs. They were thinking narrowly about the final machine that delivers. In other words, the cost of the delivery team, but not the cost of the creating team. And I think that's where I feel there is a gap in understanding that we still need to flag up and raise. And I think the fees should be higher in order to help translate some of that income back downstream to the data origin. But Yassine, you don't have to respond to that point, but you are at the other end of this relationship. You will be performing more anonymizations and pseudonymizations, and you will need to make sure the DPOs of the healthcare organizations trust you. I would trust you, but I don't know that they, because I've tracked the HDH for a long time. I know you've got very high standards, and you've described them very nicely. But the DPOs have to trust you, and they in turn have to ensure the trust of the patients of their healthcare organization. How do you see that trust being protected? You used the word fragilation, so I think it's fragilization. So I think I'd like you to come back to that word. How do you prevent that happening, do you think?
It's a tough one.
Yeah, it's a tough one. It's probably one of the hardest questions that will be in this whole conference. So you don't have to solve it. Just give a hint.
Yeah. I think I'll go back to the first question, easier, and maybe I'll have some input on the second one. So, but I think this will provide us some element to diminish a little bit the panicking effect. I still think there is challenges, but there is two things I want to say about what you were saying, and the two of your premise or the reason because you're panicking. The first one, when you said we will ask data holder to anonymize data, and if they cannot do it, to provide identifiable data in order to HDAB to process of to do the anonymization. And I think anonymization it isn't the perfect word to describe this, because anonymization, it's not unidirectional. You can anonymize data in several ways, and in the EHDS, it's not we're asking for anonymized data, is we have a question, we want an answer. So, of course, the answer has to be provided in a statistical format and anonymized way. So, in order to, so it's like what I said before when the question could be how many people have diabetes in Paris. So the answer has to be in an anonymized way. So we'll have to edit the question, because if I say how many person have diabetes in this neighborhood, the answer will help me to have information of those people. So this will not be anonymized, but this is a difference between anonymization and having a result in an anonymized format. So this is the first point, and I think it's important because it's easier.
I think it's actually a very elegant answer. Yeah. So carry on, but I think I like that answer.
And the second one is to provide and the second one is I step back a moment, and what we're doing right now, like I said before, it's request on demand. It's people come to us with a question, and we go to a database like we have basically, and we do the processing. So we don't have many experience on providing answers from database we don't have, let's say. So this is a challenge, but I think one of the responses is to do it in a federated way. So we participate in an initiative called Darwin, where a board of experts are providing an algorithm, roughly speaking, and they're providing the algorithm through different nodes, so different data holder. The data holder are processing the data through the algorithm and bring back results. This is a federated way to share results of research. And I think one of these have to be built, but I think one of the ways to secure this sharing of anonymized data is to work on this kind of federated organization where HDAB, we have to share an algorithm in order to provide an answer. Maybe we'll have to provide also tools in order to data holder to be able to anonymously or to assess that the data are anonymized and then provide the answer. So I think that the two responses, and I think if we have those, this is better for trust. But I won't go further.
Yeah, no, I think those are actually really smart answers. I like them a lot. You've got me thinking as well, so I'll keep thinking in the next few days. I think it's really great. Now, look, I'd like to shift the focus for a bit, because you've all been very passive, dear audience, and my panel have worked a bit too hard. So what I'd like to do is to now say, instead of saying, can you ask my panel a question, which means one question, 5 minutes of answers, and then one question, I want the other way around. I want you now to answer this question, but I want to just have a show, individuals put their hand up, I'll come running with the mic, but I want you to be only 1 minute. What do you see from the issues that our panel have discussed as being either additional challenges to public trust in this expanding data ecosystem, or what do you see as practices that might help retain and even improve public trust? So you can either say a minus point or a plus point in 1 minute. And I'm going to do my best to see the hands, but it is a little bright, so you'll have to wave a lot if I miss you.
Hi, so I used to work with NHS England and NHS Digital in the data access team. So it's completely different England, I get it. I've lived in Germany as well. And we have the systems set up since 2000. And I think the problem is, and this is why I would recommend to read some of the, the Gold ACRA paper and all of this, it is the media news, fake news, and also the transparency. So whilst we can be very transparent, it is the difficulty which we also raise with the panels, what you describe as the access body, to say pseudonymized data, de-identified data, and it is too complex. And when I hear Danielle, I have been there, we were actually laughing because we worked in hospitals before as well, and the same issues. But the thing is, if the transparency, so patient comes in, they trust the doctors, no question asked. But they then lose the trust if you don't put those bodies right. But I would definitely read those papers, because lessons learned from England, I guess.
Yeah, no, very important. It's always good to learn from others. Please go ahead.
I would pick the public unawareness and the huge need for the public education. And it's actually not happening. And all these developments are taking place much, much faster. And also, when I'm saying public trust, when I look on this kind of pre-starter of it, I'm living in Belgium, so when I'm looking in the like electronic patient medical files and all the systems, and I read their privacy notice, I'm a privacy specialist, there are several lies in there. The system doesn't work this way.
Several lies in there.
I call it lies. They say, like, you can identify health professionals. We will never share data with anyone else. Well, that's not how the medical field works. So, and this is like the major hit in the public trust. If already there, I'm not being told the truth. Like, will I trust anything behind it?
Yeah, no, that's really important. Yeah, absolutely no lies. I can't always see hands. Okay, I'm doing my best to see the hands. And this is my, 10 steps I'll get all day.
Thank you, Sharon Lautenbach from the Netherlands. I think primary use, we're not discussing it today, but I do think it starts there. So I think if the transparency and the rights of the individuals are really well guarded, and they can actually ensure all their rights to transfer the data to healthcare professionals they want to transfer the data to see the logging real time. If that's really a reality, I think that could really build also a lot of trust for the secondary use.
Thank you. Very good. Very well said. I saw you wanted to say, could you just pass the mic?
Yes,
Thanks.
I would say that I think it is important. I loved something you put in your slides. Is vulgarization. It's if we want to have the consent, if we want to have really all the possibilities to share the data, we need the trust, the confidence of the patients. But the first thing is to vulgarize the legal part, to vulgarize all of that, because if we remain technical, we will never be understood, and we will lose all the people. So I think that the first thing is to have the education, as you said, but to have the education not in a technical terms, not in a legal terms, but in vulgarization terms, to be really targeting the public.
Very important. Well, this initiative called Data Saves Lives, which is actually led by the European Patient Forum, is seeking to do that, to help the public to understand better. Please go ahead, and I'll run up. Yeah, I'll find you up there.
It's just a... We're talking about pseudonymisation, anonymisation. I want to go back before that and want to ask you, is it a challenge about data quality? Because we're going to be using that data. We haven't spoke about data quality. And if we're thinking about big data, we could talk about one hospital. But when we're talking about multiple hospitals and the data not being the same, data quality is not good, would that be a challenge as well?
Our institute does a lot of work on data quality assessment with hospitals. So the answer is yes, it's a big problem. And yes, they have Daniela-like no business model that helps them to invest in improving it. But we're all hungry to use their beautiful data, which is not beautiful. So there is a real mismatch. So I'm glad you raised that point.
Thank you. This is Ingrid Moerma from the Netherlands. And I'm in a medical ethical committee as the legal point of view. And also I used to work for academic medical centers at the legal department and former attorney at law in life sciences. And we heard a lot about anonymization, but that's only one way to deal with data. And if we look at Article 25 of the GDPR, it says, amongst others, anonymization. So what I wonder is, wouldn't it be wise to have more trust in the technical part and, for instance, also look at other measures that we can implement? For instance, if we would use multi-party computation, then we don't have to share the data, and then we can use in a whole different way data. So if you don't have to share and spread data, then there is no risk or a different risk.
Yeah. I'm so glad you've said that. I mean, I do feel sometimes data protection discussions are looking only at what's inside the data set and says, if this was on the internet, how revealing would it be? But nobody's putting it on the internet. They're doing the things you say.
And there are
I think
companies.
Academy, we've got to help the people who have more of a legal background to understand the technical, these things you've just said. And of course the reverse. Yeah, absolutely. I'm into democratic education. One last, if you wish. Sir, I've just seen your hand. And then I'll get my panel to sum up and then we hand over.
Yeah, my name is Toby Walden. I work for a consultancy which consults some healthcare organisations, and I worked in the UK for health by the NHS as well. I think there's one thing I think is interesting is that there's a correlation between patient trust and patient engagement. So what we saw in research is that people with rare diseases or who have a intense engagement with healthcare professionals generally have a much higher consent rate for things which might otherwise be quite difficult to explain. I think some of it is also about that engagement, and that's quite difficult. I think it's probably the thing to do is engage more and build trust by engaging more with patient rights groups and making sure that things are explained at that level.
Gosh, another really, really important point. The risk that we think of the patient as the passive recipient of our transparency, rather than an engaged co-creator of the right transparency. So thank you for that. That's a lovely final. But I have to say, all of these one-minuters were really high quality. You've had enough caffeine after all, and I'm delighted. So now I'd like my panel to take, let's just say, a max 1 minute each. Final reflective thought. You don't have to have one, but if you would like.
Yeah, thank you. There are a lot of things that have been said that are quite interesting. But I want to I will take, if I can take one thing. I think as a lawyer and as an institution, we have as a lawyer we have some ideal on, let's say, on what pseudonymized data are, what anonymized data are, and as public infrastructure, we have also fundings in order to provide a robust infrastructure and spaces to secure data. But I think what you said about we cannot do the perfect way. Everyone don't have the money, the resource to do the perfect way. So I think it's also useful to think of guidelines not as what it's the ideal thing that we can do in order to prevent misuse, but what are the realistic things that are not perfect, but that will provide the best use and that will be the more useful to every organization, and small one and also big ones. And I think that's a good way forward.
Thank you. Why don't you pass the microphone on?
Who of you remembers Vicky the Vikinger? Yeah. Many thanks. You created that moment. I remembered this federated data processing. And I think, so thanks for that. I think that could be a solution for the hospitals, because they are all on different expertise and technical levels. Why not invest time and money to build up federated systems in their rooms? Because from a German, it's called health usage data law or so. I'm allowed as a hospital to do research on my own data, so I have a legal basis. Mm. And why not use that and federate those systems, and experts like you and others bring in machines, bring in the technique, bring in the applications into our hospitals, and we do that on our own and then send the data over. So that was my thanks for that.
Okay, you two have got to have, you two are going to go to this event and talk to each other. This event, yeah. Okay. Just, yeah, keep going.
Thank you very much. So my kind of takeaway thing is that I think we are at the cusp of something different and special and new with the European health data space. And I'd like to build a little bit on what you've said about public goods. I think it allows us the possibility to think about the word protection within data protection differently, not as in protecting it from that terrible troll on the internet who's going to do something awful with it, but protecting it as a hugely valuable resource to drive public health, to make more sustainable healthcare systems, just as we've slowly begun to realize that clean water is a hugely valuable resource that we need to invest public money in. You might hear from my accent that I'm English. We don't do it terribly well in England. But I think we need to have a mindset, and data protection isn't about locking it away, but actually protecting it so that it can do the right thing in our healthcare systems. Thank you.
For my part, I would like to say, if you're a legal person or a DPO, it's such a great time to be working. I mean, the Data Act, GDPR, DGA, EHDS, and so on, and AI Act. I mean, when was life that interesting? I don't know. So.
That's a lovely note to end us on. Thank you. Well, honoured to have been able to work with these fantastic panellists. And so a final round of applause to them, and we hand over Pierre-Yves to you. Oh, you didn't tell me that.